Hello everyone, this is Anne Murray in NU 5811 and my presentation is on Wilson's disease. For the background and case study information for this presentation, this topic was chosen because of my experience as working as one of the primary nurses with a 17-year-old girl in a surgical intensive care unit. Her pre-hospital presentation included a several-month history of fatigue and heavier periods. She had been seen by an OBGYN and had been started on birth control without improvement in her periods. She was brought to the emergency room at a children's hospital after collapsing at home following what her mother stated was a gastrointestinal flu-like illness with diarrhea and abdominal pain for several days. Upon arrival to the hospital, she was noted to be jaundiced, and lab work indicated she was in fulminant hepatic failure. Gastrointestinal workup indicated that she had greenish yellow rings in her corneas, and she was diagnosed with Wilson's disease, which is a genetic disorder of copper metabolism. Her status quickly deteriorated, and she required intubation. Her kidneys began to fail, and she was transferred to our adult intensive care unit from the PICU at the Children's Hospital in order to begin CVVH and proceed with the workup for liver transplantation. She soon became febrile and was found to have MRSA in her lungs, which at the time was a contraindication for organ transplantation. She soon went into septic shock, and it was decided that she could not undergo a liver transplantation until she stabilized. Unfortunately, she died before that happened. I kept in touch with her mother after the patient's death, and although both parents were carriers of this autosomal recessive disorder, none of their other children inherited the disease. Her mother became a vocal advocate for organ donation. Although this happened almost 15 years ago, I still have the last card that I received from the patient's mother. This case has stayed with me even today, and is one of the reasons that I chose this topic. The prevalence and epidemiology for Wilson's disease shows that it's an extremely rare disorder with an incidence of about 1 in 30,000 live births worldwide. Between 1 in 200 and 1 in 500 people are carriers of this autosomal recessive disorder of copper metabolism. The mean age at diagnosis is 15.5 years. The incidence is higher in countries with a high frequency of consanguinity. There are more than 400 genetic mutations identified that are known to cause Wilson's disease, and of these, the most common mutation has the highest prevalence in Europe, specifically in Eastern Europe, and has never been identified in Sardinia, India, or the rest of Asia. The phenotypic presentation of Wilson's disease is highly variable, and it's for this reason that it's often not diagnosed until adulthood. One of the classic presentations involves a group of neuromuscular abnormalities, which are intention tremors, dysarthria, and dystonia, and these are all due to copper deposition in the brain. Another presentation, and the one of the case study that I discussed, was with cirrhosis of the liver, and it's associated with elevated serum copper levels and the presence of what are known as Kaiser-Fleischer rings in the corneas. These involve an accumulation of copper in the limbus of the cornea, which causes the greenish yellow ring to be noted. Edema and ascites may develop suddenly, or GI bleed may present as the first symptom. In some patients, the symptoms are as mild as malaise and abdominal pain, and it may also present as a hemolytic crisis due to increased copper carrying by red blood cells or in kidney failure. The diagnostic criteria for Wilson's disease include an initial neurological or hepatic symptoms suggestive of the disease, the presence of Kaiser-Fleischer rings in the corneas, as previously noted, may be indicative of the disease, and lab work shows an increased urinary copper excretion of greater than 100 micrograms per day. The normal is less than 40 micrograms a day. Low ceruloplasmin levels of less than 20 milligrams per deciliter, or a hepatic copper concentration on liver biopsy of greater than 250 micrograms per gram of dry weight. The genetic mechanisms and abnormalities of this disorder. It is an autosomal recessive disorder related to a defect in copper metabolism, and it's caused by the loss of the ATP7B gene expression. This gene is located on chromosome 13, and it encodes for a copper transporting protein, which is highly expressed in the liver, kidneys, and placenta, and at lower levels in the brain, heart, and pancreas. All of this leads to a defect in the uptake and excretion of copper by hepatocytes. Two of the major defects noted are diminished biliary excretion of copper and failure to insert copper into ceruloplasmin, which leads to an increased copper accumulation in the liver and the brain. An excess of copper in affected patients leads to the generation of free radicals that are disruptive to cellular organelles, DNA, enzymes, and proteins, and causes the eventual accumulation of copper in the liver and the brain. In the initial stages of the disease, the excretion of copper is normal as the clearance of albumin-bound absorbed copper is within normal limits. Eventually, copper receptors in the liver become saturated, and copper accumulation causes liver damage and is eventually deposited into other areas of the body, such as the brain, eyes, and kidneys. Once the copper begins to accumulate in the brain, the neurological symptoms of Wilson's disease begin to appear. Copper accumulation in the brain can also cause the patient to present with psychiatric symptoms such as delusions and disorganized behavior, but the mechanism of this presentation is not well understood. And it's important to remember that the presentation of Wilson's disease is highly variable, so there are patients that present with psychiatric symptoms but no liver damage. They may present with the neuromuscular abnormalities mentioned, or they may present with the hemolytic crisis, as was mentioned before. The current management strategies for Wilson's disease. It's important to note that without treatment, Wilson's disease is fatal, and early diagnosis is very important to prevent the longer-term organ damage that can result. However, as indicated, due to the very variable phenotypic presentation and the rarity of this disease, many physicians have not seen this disorder. The mainstay of treatment is chelating therapy, and that works by binding excess copper and facilitating urinary excretion. Penicillamine is usually recommended as the initial treatment. It was initially thought to remove copper from circulation, but now later research suggests that the copper is converted to a non-toxic form. Neurological symptoms can get worse on penicillamine, in which case a medication called trientine can be used. Trientine has a lower side effect profile, but its long-term efficacy in copper removal is not well established, so penicillamine continues to be one of the drugs of choice, but as mentioned, it can have a higher side effect profile. One of the other chelating strategies used is zinc sulfate or zinc acetate, and that works by inducing production of metallothionein, which binds to copper and reduces the intestinal absorption and detoxifies it in the liver. Zinc is not usually recommended as the initial therapy and is most often used in conjunction with penicillamine, although there have been patients that are started only on zinc therapy due to their history of reaction with penicillamine. Patients are also advised to avoid foods that are heavy in copper, such as chocolate, nuts, and shellfish. And for patients that present, as my case study patient did, with fulminant hepatic failure, oftentimes liver transplantation is indicated as the initial treatment of choice for patients who present this way, and in those patients, it is considered curative. There are several social, financial, and ethical considerations in Wilson's disease. In the case study that I mentioned, the patient's mother expressed that she carried a considerable amount of guilt knowing that she and her ex-husband were both unknowing carriers of Wilson's disease and had passed the disease on to one of their children. Although, as previously mentioned, the other 3 children the couple had did not have Wilson's disease after molecular genetic testing was performed. Wilson's disease is considered an orphan designation, so funding for research and initial therapies is often inadequate. Prenatal testing is available for Wilson's disease, but as an autosomal recessive disorder, if both parents are carriers, there is a 25% chance that they will have an affected child. It is not considered cost-effective at this time to screen all children for this rare genetic disorder. The next slides involve references, and this concludes the presentation on Wilson's disease.